Good evening, everyone. Welcome tonight to our presentation on electronic prescriptions for GPs, their practice managers and specialists. My name is Alison Tattersall and I'm the Workforce and CPD Team Leader at the Primary Health Network. I would like to acknowledge the traditional owners of the land on which we meet tonight and pay my respects to elders past, present and those emerging. Tonight you're able to ask questions through slido.com and the code for tonight is prescribers. To do the evaluation at the end tonight is also through Slido. Tonight I would like to introduce Kerry Doolan and April Burnett from the Australian Digital Health Agency. They'll be doing your presentation tonight. They are both provider adoption leads for the Australian Digital Health Agency. The presentation slides and tonight's streaming event will also be available on People Bank on the PHN website after 24 hours. Thank you, Kerry.
Thank you very much, Alison, and it's a pleasure to be here with you tonight to give you some information about electronic prescriptions. April and I are part of a wider education team that have been educating GPs, specialists and pharmacy on this for the last few months. The interest in the subject's been quite huge, so we really appreciate seeing such great registration numbers here tonight as well. As mentioned, we're provider adoption leads. I've got a background in community mental health nursing prior to going into digital health work in 2006, and I've been around the digital health space since then. Some of you might recognise me from some My Health Record education, but electronic prescriptions are quite different to My Health Record, as you'll soon find out. My colleague April Burnett has previously worked in pharmacy and in the North Sydney area and has been with our team as part of electronic prescriptions education since the beginning of the year. We'd also like to acknowledge the traditional custodians of the land upon which we meet and their connection to land, sea and country. I'm joining Alison in Awabakal country and April's joining us from Cadigal country in Sydney. So please, as Alison mentioned, there's a Q&A section of Slido where you can raise questions and we'll tackle most of those questions towards the end. And also at the end, there's in the polls section of Slido, you can click on that and complete our evaluation at the end. So now I'll pass over to April to move forward with the presentation. Thank you, April.
Thank you, Kerry, and thank you everyone for joining us tonight. The purpose of this evening's webinar is to introduce you to electronic prescriptions. So we will be running through the role of the Australian Digital Health Agency in this and provide an overview of the roadmap for delivery. Electronic prescriptions was already on the national agenda for this year. However, the timeline for this has been accelerated as a response to COVID-19. So we will be touching on the adjusted short-term priorities while also running through the long-term solution as well. We'll also be exploring the features and benefits of electronic prescriptions, including a case study demonstrating what this may look like in your workflow. Further to this, we will be clarifying what you and your organisation needs in order to be ready for electronic prescriptions. So the Australian Digital Health Agency has a roadmap for delivery of the National Digital Health Strategy. Electronic prescriptions is a key priority of the Medicine Safety Initiative, which is one of the 7 domains of the National Digital Health Strategy. This is a 4-year roadmap that runs through to 2022, so we're currently right in the middle of that timeline. The agency has completed meaningful work across all 7 elements of the strategy in the past 2 years, and other areas in this strategy include My Health Record, as Kerry mentioned, but also interoperability and data quality and driving innovation. The consultation for the strategy revealed that Australians want to be able to manage their medication and request prescriptions from their mobile device. In particular, electronic prescriptions aims to ensure that there is a digitally enabled paper-free option for medication management in Australia, and this is now more important than ever. So electronic prescriptions will support consumer safety by reducing the risk of transcription errors and also assist health professionals by reducing unnecessary paperwork. And this is being done in a manner that maintains patient privacy and integrity of personal information. The Department of Health and the Digital Health Agency have been collaborating to implement electronic prescriptions. This includes developing the technical components, the conformance framework, and the national change and adoption activities. As you can see from this slide, the work on electronic prescriptions commenced in 2018. And to give you some background on this, Commonwealth level legislation changed last year in order to recognise an electronic prescription as a legal form of medicine supply. When that legislation changed, the Digital Health Agency published its technical framework. The technical framework details the requirements for software providers to make changes to their software products so that it ensures their software is aligned with electronic prescription legislative framework. And this ensures adherence to privacy and security principles and maintains that patient choice. The technical framework has been co-designed with different stakeholders through the agency's electronic prescribing technical working group, and participants in this included the medical software industry, health professional peak bodies, consumers, and government. The agency is also responsible for change and adoption, which is another significant piece of the puzzle to ensure that prescribers, dispensers, and ultimately consumers are aware of how electronic prescriptions will work and what they need to do to be prepared. Okay, so here is a brief overview of electronic prescription implementation. The timeline outlines the Australian government's recent measures announced in response to COVID-19, but also the long-term electronic prescription solution. Currently, there is a special arrangement in place that I'm sure you may have heard of, or maybe you've worked with this before. And this is whereby prescribers can send a digital image of a prescription to a pharmacy. That arrangement is a short term solution announced in response to COVID-19 as part of the National Health Plan. It's not the same thing as electronic prescriptions. And that is an initiative, it's called Prescriptions for Telehealth, and that's an initiative managed by the Department of Health. So if you do have any questions about this, I recommend referring to the Department of Health specific advice. Right now, progressive rollout of electronic prescriptions is occurring. So, what electronic prescriptions means is that a token model will be available for software providers to implement in their product. So, prescribers will be able to generate an electronic prescription through their conformance software and send that as a token, which is a unique QR code, and that's sent to the patient electronically. At the pharmacy end, the pharmacist will then scan the QR code and download the prescription details. This token electronic prescription model will be the focus of our presentation today. So currently, software developers are in the process of validating new software in communities across the country, and it has been imperative to roll this out on a small scale first to ensure that any technical issues are sorted and workflow implications are worked through. Um, as a result of this staged rollout, communications will be tailored depending on the readiness of each location. So finally, from late 2020, the active scriptless model of electronic prescriptions, in addition to the token model, will be available. And I will go through the differences between these two models on a slide soon. But as you can see across the different phases on this slide, the paper prescription option is consistent, and it's going to always be an option for patients and prescribers. So it's very important to keep that in mind. So what are electronic prescriptions? Electronic prescriptions are an option for your patients to use an electronic prescription as an alternative to a paper prescription. So they're not mandatory, and paper prescriptions will still be available. The difference between an electronic prescription and a paper prescription is that the legal entity is an electronic document, and that's authenticated with an electronic signature. So, as I mentioned before, Commonwealth level legislation changed last year to recognise an electronic prescription as an alternative legal form by which medicines can be supplied, but the prescription is still required to meet state and territory legislation as well. It is important to note that this is the patient's choice on whether they're receiving a paper prescription or an electronic prescription. So the key benefits focus around providing greater choice for patients to access their prescriptions. For example, they will be able to share an electronic script with their community pharmacy without the need to be physically present at the pharmacy. So let's have a look at the two different models of electronic prescriptions. So it's the token model and the active scriptless model. Australians want to manage their health on their mobile, so both of these options offer patients the choice to do so in a secure way that maintains patient privacy. So first we'll touch on the token model. So there's an example of the token model just to the left of the screen there, and this is a unique QR barcode that is scanned to issue medicines prescribed in the electronic prescription. It's important to note that the barcode itself is not a legal document. It's only the manner in which the electronic prescription is accessed. What I mean by that is that the barcode acts as an evidence of prescription, and then when it's scanned, it then downloads the prescription information from the prescription delivery service. It's every one unique token is issued for one medication. So one prescription item, one token. And that token model will be progressively rolled out from the end of this month, but adoption will vary between different locations. The states and territories are at different levels of readiness. And some um, doctors at the moment are prescribing electronic prescriptions through this token model, and we'll touch on the different areas that are doing that soon. The next model is the active scriptless model, which is to the right of the slide there. So following presentation of adequate identification, the pharmacist can retrieve prescription details for a patient from their active script list. What that means is that the patient will grant their pharmacist access to their active script list, which is essentially a repository of all their current prescriptions. The benefit of this is that it does mitigate the issue of lost tokens, and it's suitable for those on multiple medicines. For both of these models, full prescription details are securely stored in the prescription delivery service. So as we've mentioned before, the focus of electronic prescriptions in the short term will be the token model, which is on the left-hand side, and this is the model that's been accelerated as part of the National Health Plan for COVID-19. The active script list is a more complex solution, and this is going to be rolled out towards the end of 2020. So who can participate in electronic prescriptions? There are many stakeholders involved in the implementation. So there's prescribers and dispensers, and the agency has been working with peak bodies in pharmacy and medicine to deliver this. Software developers are also largely involved in the delivery of this. So participating prescribing and dispensing software products must go through the process of conformance to ensure that their product is aligned with the necessary requirements. But so you have the prescribers, dispensers, and the software products, but it's ultimately consumers who are at the center of this. Consumer participation is really important to the change, and we have been working on consumer awareness resources to support Australians in understanding what electronic prescriptions means for this. So for the system to work, the consumer must have an individual healthcare identifier or an IHI. This is the number that identifies the patient who's receiving care to ensure that the right information is associated with the right individual. The IHI is also the healthcare identifier used in the My Health Record system. And as this uses the same infrastructure as My Health Record, a common question that we get is, can a patient access electronic prescriptions if they don't have a My Health Record? And the answer to that is yes. So every Australian with a Medicare or a DVA card has that IHI, and therefore they can still participate in electronic prescriptions even if they don't have a My Health Record. Another key element to keep in mind when talking to patients is that an electronic prescription can't be converted into a paper prescription and vice versa. So the patient will have to decide at the point of where the medication is being prescribed on whether they are deciding for a electronic or a paper prescription. Now, electronic prescriptions will have a staged rollout across Australia due to the individual state and territory level of readiness. Most states and territories now have legislation that recognises electronic prescriptions for medicine supply, and it is really important that prescribers and dispensers are referring to their relevant state advice as they are still required to adhere to any local regulations when using an electronic prescription. The good news is that for New South Wales, legislation is ready for electronic prescriptions. So on a Commonwealth level, legislation commenced on the 31st of October last year, and updates to software conformance profiles have assisted software developers in enabling this feature within their product. Then, of course, individual states and territories have been working on aligning their legislation with the Commonwealth. So these updates are quite recent, and the states that aren't participating are working on enabling that legislation in the next coming month. So the requirements to participate in electronic prescriptions, they're not the same across the country. Okay, so here is a screenshot of the current electronic prescription conformance register. This means that the software listed has undergone testing to ensure that their product is aligned with the agency's technical framework that we've mentioned before. And we will be maintaining this list as soon as new conformance software becomes available. And the information is available on the public domain. So there is a link to the conformance register just here. And if your software product isn't listed on the list, they might be working towards conformance in the near future. It's important to note that just because the software provider is listed on this web page as conformant, it doesn't mean that all their customers will have that electronic prescription functionality enabled within their software. Each software provider has different timelines on how they're rolling this out. So it's really important to contact your software provider to see where they're at with their rollout of electronic prescriptions. So as I mentioned before, electronic prescriptions are currently being progressively rolled out through a number of communities of interest. And this is to ensure that any technical or workflow issues are addressed on a small scale. And the broader rollout will take place as more software providers progress through their conformance testing. A community of interest is at least one general practice and one community pharmacy in a proximal location. And both of those organisations have to be electronic prescription enabled. So Anglesea in Victoria was the very first community of interest, but there have been many since that have been rolling out electronic prescriptions on a small scale. Initially, this is validating that token model, and we expect that the active scriptless model will be included in communities of interest from August this year. So progressive deployment of electronic prescriptions is occurring in a steady and managed approach, and it is expected by September this year. Okay, so I encourage you all to continue posting questions in the webinar feature, but I'll now pass over to Carey, who will take us through a case study and a look into what electronic prescriptions will look like in practice.
Most common questions we're asked are electronic prescriptions similar to the paper model, where someone other than the patient can present to pharmacy and get the medicine dispensed? And this case study is an example of where a parent or a carer can have the electronic prescription dispensed. So Julian's a 4-year-old boy. His mum found that he was febrile and had a sore throat. They were quite concerned, so made an appointment at the GP practice. The doctor saw Julian and prescribed utilising an electronic prescription. Mum was aware that the pharmacy around the corner from them had already commenced utilising electronic prescriptions, so they opted for an electronic prescription to be sent by SMS to the mobile phone number of mum. And the parent then attends the pharmacy and presents the token via the SMS to the pharmacy to get dispensed. And then the pharmacy can scan that token utilising the QR code, which is hyperlinked off the SMS message. And then they can dispense electronic prescription. Once it's dispensed, it's no longer active. So once the medicine has been given to the patient or to the parent or the carer, that QR code is no longer active, and if there's any repeats, then they are automatically generated again. And if Julian had some repeats there, that would auto-generate an SMS token again. This is an example screenshot of one of the software providers implementing electronic prescriptions. So this is an example screenshot from best practice. You can see it's in the ERX tab, where we've got some new functionality in the latest version. I think it's Jade 3, and in there you can select which option the patient wants to receive their token, whether it be via SMS, email. Now that can pull from the mobile phone number or the email address that's already in the software for the patient in the client details. So for example, your practice might utilize SMS or emails for reminders. So it's utilizing those same fields. Alternatively, if we need to enter in a different mobile number or a different email address, we can select SMS other or email other. And then it's a matter of selecting that option, then hitting the eScript button just to the left of that to send the eScript. These screenshots are simply examples of receiving the token into SMS onto the mobile phone. So it comes in to messages in date order of being received. There will be a prompt to click on a link, which is hyperlinked to the internet, where the actual electronic prescription or the evidence of the prescription is what we say can be viewed. And that's what it looks like on the right hand side there with the QR code, the initials of the patient, medicine details. That's the core of it. So a bit of medicine information and the initials of the patient. If the patient opts for an email option, then we've got an example on the left of what an email option might be looking like. With all the different combinations of ERX or MediSecure with BP or with other software types from pharmacy, the actual branding that appears on the evidence of prescription or the QR codes, the branding might change and might look slightly different from message to message. But always we'll get that QR code there. On the right hand side, there is an option to be able to print. So if we were to print it out, it's still an electronic prescription because it's got the QR code, even though it's on paper. This just demonstrates that when the patient goes or the QR code arrives at the pharmacy, it's scanned. Now that could arrive by the patient turning up or a carer or parent turning up with the actual with the phone and the QR codes in the SMS or email, and that can be scanned from there. Alternatively, if the patient was isolating or remotely requesting their medicines to be dispensed, they can send it to a mobile phone number at the pharmacy or forward the email to the pharmacy, who can scan it off the screen. So there's a few different options there for scanning. This slide just demonstrates the fact that when the QR code comes in, it's hyperlinked, and so what that means is that if the medicine was expired, so if the prescription had expired, so similar to paper prescriptions, there's still an expiry date attached to prescriptions. If it's expired, then when clicking on that link, it'll state that it's expired. It just will not demonstrate, it will not display the QR code. Same for if it's already been dispensed. So remember that one QR code can be dispensed once. And if there's any repeats, that'll be auto-generated and sent to the same method that it was received. So the prescription might have already been dispensed, and so that way we know that that one's out of date, and we're going to look for the next one for that associated with that prescription. And then we've also got the option for it's been ceased by the prescriber or cancelled. So that's a good example of a difference and a benefit really of electronic prescriptions. If it was cancelled, expired, the paper version doesn't give you that sort of messaging. So this is will be interesting to see how that plays out. These are a few example scenarios that we're often asked. So if the patient is unable to receive a token, for example, they don't have a smartphone, what options do they have? Well, they might have a carer, or they might have someone else that they can request receive the token. What if the token's been sent to the wrong number or email? So firstly, we want to have a process for checking we've got correct mobile phone number or email address, perhaps checking with the individual. But also when you send a prescription, so you've sent an electronic prescription into the system for the patient, then you will get a notification to acknowledge that it's been received successfully or it's been sent successfully. You'll receive that immediately. And we're also recommending that it could be considered for checking to ensure that the patient receives the token prior to perhaps leaving the practice, so that if they haven't received it, then they can notify staff to receive some assistance there. If it's sent in error, the prescriber can cancel the prescription and generate a new token. Accessing prescription repeats, we've said that they are automatically reissued upon dispensing. Patient deletes a token from their device, so the prescriber can resend the original or the latest repeat token to the patient, as the prescription remains in the PDS until required by the patient. Are there safeguards to prevent patients utilising the token at multiple pharmacies? Again, once it's been dispensed once, it's no longer valid. So therefore, even though you can forward a copy of the token to multiple directions, once it's been dispensed once, it cannot be utilised any more than once. Will the software cater to different legislative requirements? So in New South Wales, it's been very straightforward in this state in regards to the legislative requirements. They've been passed for some months, and there's no particular anomalies with the software. Whereas with our colleagues in some of the other states like Tasmania, they require a different field when prescribing, and that's been accounted for in the likes of best practice, medical director, etc. What certificates do I require to participate in electronic prescriptions? So that's asking the question, do we need a NASH certificate or do we need a Medicare PKI site certificate? It depends on your software and how they connect to the healthcare identifier service. So the HI service is the way that these identifiers are authenticated. So those identifiers being the patient's IHI, the provider's HPII, and the organisation's HPIO. So it is utilising those identifiers and certificates similar to the My Health Record system. Even though we're utilising similar technology for security and authentication, it's a separate system to My Health Record. So you can have electronic prescriptions set up in your practice, and you can choose not to utilise My Health Record. Of course, we hope you are gaining benefit through My Health Record and are utilising both. Does electronic prescribing also work for prescribers if ERX or Metasecure is not installed? So ERX or Metasecure is an essential part of it. So that's the process of the data being transmitted and also stored in a legal prescription format. So it does follow the same pipes, if you will, as what the paper electronic transfer of prescriptions model follows. So currently when you do a prescription, you might have a barcode coming out on the paper prescription as it is at the moment, utilising ERX or Metasecure. It'll be utilising the same technology but in a different way, sending different data and stored in a different way. And that element we don't call electronic transfer of prescription. We call that prescription delivery service, but it's still ERX or Metasecure. Is there a cost? So certainly until the end of September, the costs are accounted for through the Department of Health as part of the COVID-19 allowances there. Following 30th of September, your software provider will advise if there's any costs. We've observed that there can be costs associated with the SMS option, whereas with email it's utilising internet options. But do check with your software provider for more information in regards to certainly SMS costs. This is the readiness checklist that we've been sharing with providers, and essentially it's connectivity with the HI service is important. So if you are currently connected to the My Health Record system, and if you have ERX or MediSecure currently installed, you are ready and waiting for the software to be ready and available to upgrade and implement for your practice. However, if you are an organisation that's not connected to My Health Record, or you're not uploading, or you know that you're not connected, then it's a process of having the registration take place for the HPIO, the Healthcare Provider Identifier for your organisation, having that registered, identifying your HPIIs and having the software provider help you put that into your system. Checking with the software provider, do they need a NASH certificate or a Medicare PKI site certificate? Some require both. Some currently require Medicare PKI only. As the next 18 months roll on, NASH HI service will move more towards NASH for utilising for HI. Having ERX or MediSecure installed. Update your patient or carer's contact details. Some of the PHN staff tell me that that's commonplace as part of the reminders process, but if not, then that's certainly something that can support your practice be ready, is to check what the mobile phone number and the email address is for patients and their family. Stay up to date with state and territory legislation. Well, we've gotten you up to date that we're ready to roll from legislation perspective in New South Wales. Queensland's a little bit further behind, but we anticipate that'll catch up very soon. Consider any workflow elements, any workflow considerations in regards to, workflow considerations that you may or may not have. There's not a huge change for GPs and specialists, except to be aware that we want to have a process for the patient to be able to let staff know if they haven't received the token, so that can be troubleshooted if required. Keep in touch with the local healthcare providers. So what we want to avoid is a patient getting a token and they have no pharmacy to go to have it dispensed. So an essential element of this implementation is understanding when the pharmacies in your area are ready to dispense, so that at least you know that there's at least somewhere where the patient can go to get their token dispensed. This may not get implemented in a big way for a good few months yet, because of the time it will take to get the communities of interest completed. But just stay abreast with the communications coming from coming to you, and certainly as a basic rule, please liaise with the pharmacies in your area to stay up to date with when they're ready for dispensing. There will be other modes of resources and information coming to you. On the Australian Digital Health Agency website, we've got a e-prescriptions webpage. We've got a link here which we'll share with the slides up the top there on the left. There's prescriber and dispensing page web links, and that includes the list of software that's become conformant. The table that you saw that April shared before, that table demonstrates that the software is conformant and has passed the test that it can do electronic prescriptions for the token model, but it doesn't say that it's ready for the market, that the market's receiving it and able to upgrade as yet. So certainly a key port of call is your software providers to understand when they're ready. Webinars, we've done some webinars by the agency for GPs and specialists. We've been collaborating with the RACGP and also the Royal Australian College of Physicians to ensure that there's maximum awareness out there. We're soon to collaborate with Hunter New England Central Coast Primary Health Network for a pharmacy event on the 30th of June. So if you've got any colleagues or stakeholders in pharmacies, that you think should hear a bit about this and ask some questions, please point them to the PHN website on for the 30th of June event. There are fact sheets on the website. E-learning modules are coming soon. I'm told that could be next week or this week. So some e-learning modules as an option as well. Department of Health are very central to the program, so they've got a web page. And again, the software providers are very, very essential with this rollout. So now we've got some time for Q&A, and I'll just pass over to Alison to moderate the questions for myself and April to answer. Thank you, Alison.
Thanks, Kerry. So we have got some questions. So Kerry, to you, the first one is, does the token system mean the parent cannot check for errors in the prescription?
So the token will have the medicine information, so what medicine is it, the initials of the patient and the QR codes. They're the basic makeup of that token. So if the initials were wrong, if the medicine was not for that individual, yes, that's an opportunity for saying, this is not for me. Just like it is if there was a paper prescription received with the incorrect information on it.
Thanks, Kerry.
That's right.
The next one. So this is from Christina. Is the script valid for opioid scripts? April, are you still there? Okay, Kerry, it's over to you.
So in regards to opioid scripts, yes. So there's no, based on legislation prescribing, they certainly will be allowed to be prescribed for. Depending on your software, there may be a requirement to re-enter your password as part of the security measures in place for S8s and other controlled medicines. But in terms of authority process, that still takes place. But there might be a requirement to enter in another password, but there's certainly the only medicines that, well, there's no real restrictions on medicines being prescribed via electronic prescription. So even private prescriptions, not just PBS, can be prescribed by the electronic way.
Thanks, Kerry. Another one from Christina. Is the QR code stealable, thinking with the context of drug seekers? There's
a kind of an element of control. So with a paper prescription, it's not as secure, I guess, but if the SMS or the email was forwarded, then I suppose if that's gone to another individual, that's an element of control over where it goes to. Whereas with a paper prescription, it can theoretically be pinched out of a bag, etc. But in a phone or a computer, generally that's behind a password. So we personally think that in terms of the integrity of stealing, we'll be in a better place with electronic prescriptions.
So I'm not sure if you've covered this. Can opiate script be transmitted via eScript?
Yes, it can. Yeah, so any type of controlled medicine will be able to be prescribed by the electronic model. You might have to enter in another password into your software depending on the software. And there might be other elements, other steps according to your normal prescribing requirements by your state legislation.
The active script list, does this mean that it would be really hard for a doctor shopper to get multiple scripts?
Is it hard for a doctor? Yeah, so in terms of active script, it really is the full solution. And with that means that there won't be any scripts lost. With a token, we can potentially delete it and lose it. Email is a bit harder to delete. It goes into a trash box. So if we've got patients that might, delete accidentally, email is probably a better option, but we can still lose them. Whereas with the active script, they can't be lost. They go up into the PDS again and are stored up there. The patient provides 100 points of ID to the community pharmacy and gives consent for the pharmacy to draw it down. In effect, the patient doesn't have to handle all those tokens and things like that, so it'll be far easier to manage medicines for people with complex medication histories. So for example, a patient with a Webster pack, it'll be more ideal for them to move into that active script world where we'll get the full solution.
Okay. So just a reminder, on slido.com, it's hashtag prescribers if you want to ask a question. So this is from Sally and Beck. So the parent or patient cannot see the dosage on the electronic script? Question.
They can. So the screenshots that we've got have the medicine name, the dosage, but not whether it's Nocte or BD, etc. It'll state medicine, milligrams or mils, etc. Initials, and that's generally about it. It might say a bit of branding, the QR code, that's generally it. So it's very limited in terms of the information on there. When the pharmacy scans that QR code, they get the full legal prescription. So the QR code is not actually the legal prescription, it's the legal prescription is the electronic version that comes straight down into the community pharmacy software. And that comes through with all the details that are associated with the prescription, the full details that have been shared by the prescribing software to the PDS, and that's drawn down to the pharmacy software.
Thanks. Kerry, is there a way to send an SMS from your computer?
So the SMSs will be generated, my understanding is they'll mostly be generated by the likes of ERX or Metasecure, but we'll possibly utilise other elements to account for costs, particularly for SMS. So there's no extra steps that are required for you to set up SMS than what you already might have. ERX and Metasecure, together with the likes of Best Practice and other software, will handle the generation of that SMS. So there's no real extra steps to setting that up.
This is from Cameron. Will there be any rollout into secondary care?
Secondary care being hospitals? Yeah, so good question. So there is a plan for hospitals, but it's separate to this. So this model is going from, well, basically primary care to community pharmacy. However, with hospitals, there is a different process that will be implemented. That could be a good year to 18 months away from solidifying, but this application will be primarily for the community.
If you're picking up a medication for a friend or family member, what identification do you need to provide?
No different to currently. So the pharmacists, and just chime in if you can hear us, April, no different to currently. So my pharmacy colleagues, I've got several, they tell us that when patients are coming in, they ask a range of questions. A little bit about allergies, how long have you been taking this for, a little bit about the identification, what's your date of birth, where do you live. There's a range of kind of assessment questions that are coming from a perspective of not only clarifying that is this the right person, but is this the right application of the medicine? And if there's risks associated with that, then they can pause it, check with the prescriber, or consider the options for the patient from there. So no different to currently, but normally it's a range of questions that are asked to make certain that it's the right move to dispense the medicine for that individual.
Thanks. If a patient changes the dose of that medicine before the old repeats are used, are those deleted?
Good question. So if the prescription's changed, if it's been dispensed already, So if the first dispense has taken place and then there's a change, then it's a process of the prescriber has to cancel that prescription in order to cancel the subsequent ones. If the first dispense has not taken place, so if the token has been taken and there has not been a dispense as yet, then that can be changed and resent in order to account for that. So it's quite straightforward if it hasn't been dispensed yet, but if it has been dispensed, then it needs to be cancelled. It won't automatically just change it after the first dispense has taken place.
If the patient first requests for an electronic prescription and then later asks for a paper script, will the doctor be able to change to the paper script?
No. So it's you start and commit to the electronic prescription model. So that's where it's quite key to understand, are there any pharmacies that we can get this dispense from before pursuing it? So it could be a little while before we get to that point, but just liaise with the managers at the pharmacies to check in with them before we start giving those out. But if there's a sudden change of heart and we want to go back to a paper prescription as it is now, then it'd be a case of cancelling that electronic prescription and then moving to the creating a new paper prescription.
Yep. If a medication is ceased, can we cancel the token? For example, antidepressants. If we increase the dose the next month, can we cancel the old script?
Yeah, absolutely. Yeah, cancelling is very straightforward in the software.
Can you send the token to the pharmacy only without giving any to the patient?
Good question. So the design of this token model is not to do that. The design of the token model is to share it with the individual so they've got choice as to where they go to get it dispensed. For our patients that would benefit from us sending it direct to the pharmacy, that's where the active script is made for them. So with the active script list, it'll come towards the end of this year, and that's where we will send, we're basically updating an active script list, an active list of the current medicines that are active for that patient now, updating that list, and then the pharmacy, using the patient consent and 100 points of ID, can pull down the medicines that are required. So potentially a lot of that faxing can go by the wayside once we get the active script list, but we wouldn't recommend utilising that method for the tokens. The token model is built around the idea that the patient has that choice and control. Of course, if you've got special circumstances and special arrangements that have been agreed upon outside of the software, where you're sending the script to the pharmacy, you can change the mobile phone number and the email address, and you can technically do all that. However, it's not the method that's been utilised in the design of it. Having said that, if a pharmacy's given, say, an emergency supplier, or they've given an urgent dispensing for the patient and they've given that to the patient and they're in the pharmacy, for example, the GP or the specialist can make the prescription. In the software there's a script owing tick box. You can select the script owing, and what happens there is that the script owing process will send that script straight to the community pharmacy's system, bypassing the patient. BP is saying, best practice is saying that if you're doing that, it's a requirement to print off the paper token and send it to the pharmacy, but not all the software types are saying that. So there's a little bit of information that your software provider should give you if you are looking to send it direct. But the design of the token model is for it to be shared with the patient, and for those other patients that we're faxing or wanting to send it direct to the pharmacy, best to wait for the active script list.
Okay. Are GPs able to check if a token script has been dispensed if a patient reports a lost QR code, but we want to double check?
Yeah, well, that is a beauty of the system, is that once it's been dispensed, it's no longer active. So one option is just to simply tap on the hyperlink that's in that SMS or email. That pulls down the information on the evidence of the prescription, and if it's expired, if it's been dispensed already, you'll get that screenshot that we showed before where it says that this medicine's already been dispensed, so the patient can check that there. There's no way from the software to see if it's been dispensed for the token. However, with the active script list, you will be able to see where things are up to with that script list.
Is there a process, this is from Karim, is there a process for signing scripts electronically, or any staff member would be able to do that if you accidentally leave your computer open?
Yep. Good question. So good security process is to have passwords unique to each person in the practice. When setting up electronic prescriptions for the practice, it has to have the provider number in the user settings, the HPII, the APRA number. So there's a few little things there that basically equate to a signature. And then it's a case of the password process being secure, and then, you know, they're the key things that have replaced the signature.
This is from Sheila. What happens if a specialist changes the dose or medication and we're not advised?
Good question. So if the specialist has changed the dose and the GP has not been advised, does the token model solve that? No. However, that's where things like My Health Record can come in. So once the medicines have been dispensed through the token model, there's no real trace history that is viewable to any provider. It's auditable, so like most, or if not all electronic systems, one of the benefits of those is that they can be auditable. So if there was ever a problem, you know, contacting the software provider can generate audit trails. However, that trace history, that history will remain mainly in the clinical software of the various providers, but that's where My Health Record really comes into its own, because it's quite rich of medicines history. PBS history automatically goes up. Private prescriptions are going up in droves through the community pharmacy integration. And so even if you have a specialist that is connected to My Health Record, and if you have a GP that's connected to My Health Record, and they've both selected, you know, their practices have selected that they'll both do electronic prescriptions and they're set up for My Health Record uploads, then that's where that history can be viewable and can be transparent that way. So of course that's a benefit of My Health Record, is collating that historical information.
Thanks, Kerry. What would happen with methadone or Suboxone scripts?
Yeah, so I'm not familiar with all the ins and outs of the actual script model, but so for the prescription process for those, but I've been told multiple times that all of those can be prescribed electronically.
Okay. How do you prescribe daily dispensing medication like diazepam, especially if it's a patient with a risk of overdose?
Yeah, so whatever checks and balances currently exist for prescribing those, it's the prescription, the electronic prescription, all that does is replace the bit of paper. That's all it does. There might be an extra passcode to enter in, depending on the software setup, but all the electronic token does is replace that one prescription. So if there's authorities required, if there's other steps to take into account for the assessment process, those processes go on without any change. The only change is that the electronic prescription replaces that bit of paper. So
Christina would like a tutorial in person. Who does she get to show us, the software provider or the PHN?
My recommendation would be the software provider, because whatever software you're using, they'll be able to provide you with the real required information for your unique circumstances. The PHN as it stands are not set up to provide education in this regard. The software providers have been doing some webinars already, so Best Practice have done a webinar already. ZMed have done a webinar. Medical Director have recently gone onto their website and said that they will soon do some electronic prescription functionality in their software, but they are currently not on the conformance register. And what I've noticed is the software types do similar things but slightly different. So that's where it'd be key for them to do that. In time, it's possible that the PHN will be geared up for that. If anyone's familiar with the on-demand training environments on the Australian Digital Health Agency website, we haven't yet seen it, but hopefully at some point we'll be able to have a play on there and be able to do a bit more demoing via the PHN. But for the time being, I'd certainly recommend for the nitty-gritty demos and things like that, talk to the software providers.
Can patients access electronic prescriptions from only one pharmacy, for example, Travellers?
Sorry, say that again.
So can patients access electronic prescriptions from only one pharmacy? And then it's example,
good question.
Travellers.
Yeah. So any pharmacy that can dispense an electronic prescription can do that. So if you've got a patient that's got 6 repeats, they've gone around Australia, for example, they'll be able to have it dispensed at each pharmacy that can do electronic prescription dispensing. So you don't have to keep going back to the same pharmacy. If the patient turns up to a pharmacy and finds that the code's been scanned at the script in counter, and then the pharmacist's gone around the back and found that they don't have any stock, then that code is still active. It's still active until they've gone out the door with the medicine and it's been scanned and tapped out of the clinical software in the pharmacy. That's at the point that it's no longer active. But if the patient hasn't had their medicine dispensed, even if it has been, checked by the pharmacy, the patient can go on to another pharmacy and another pharmacy and another pharmacy.
Okay. Is there a database or way to know which community pharmacies are capable of receiving these patients?
Not currently. It has been thought about, and currently it's not, there's no real capability for any of us to sort of, for example, once a pharmacy went live, has been ticked off the connected list by, say, the software provider, it's then the human element as to whether it's been implemented or not, and keeping track of that is the key bit that we're not able to set up a database for easily, at least. So initially the recommendation is to just liaise with your local managers of pharmacy. We anticipate that certainly in time it'll be the consumers that are aware of which pharmacies are dispensing these electronic prescriptions, and so there'll be less reliance on, say, the practice manager or the pharmacy manager understanding where things are at locally. But as things are, I'm sure the consumer model, the consumers will be the ones that are telling us where they can get it dispensed.
Okay. So this one again is from Sally and Beck. So essentially, if you do not have a Medicare card, you cannot get an electronic prescription. Is this correct? And for example, international students.
Yeah, good question. So for having an IHI, which is one of the fundamental things for having an electronic prescription, that helps identify the unique patient in the system. You need to have a Medicare card or DVA card number in order to find the IHI to populate it into the software, similar to My Health Record. So unless the individual, and if they're a new arrival, they might have a Medicare card. There are fairly good processes there, but of course it's quite possible that they don't. And if there's no Medicare card or DVA card number, then the IHI will not be able to be found. Similar to my health record, to find the IHI, the system needs Medicare card number or DVA card number, date of birth, gender, name. They're the key things that need to be in the system to match with the healthcare identifier service, utilising those certificates we mentioned before.
And we've got one more question. Yep. Will paper scripts fade out in the near future? If so, when?
Definitely not the near future. There's no sign of paper prescriptions going anywhere for any time soon. If the sort of thinking that the government has is that, this may take 10 years to really accelerate for wide use. Having said that, we have noticed tremendous interest in electronic prescriptions. We've had 1,000 to 2,000 people attend some of the webinars. So the interest is massive. It will be sort of a slow, sort of gradual rollout, particularly when we think about hospitals. And it may take a long time for it to get to a point where we might even ever consider letting go of paper prescriptions, but I certainly don't anticipate that for 20 odd years at least.
Yeah. Okay, is there anything you wanted to add, Kerry?
No, I guess the key message is just, if you are already connected to My Health Record, you're pretty much able to just wait for the software providers to connect, and then it's understanding a little bit of the functionality there. Please loop into other conversations that might take place through RACGP, the Royal Australian College of Physicians, and through the PHN and through the Digital Health Agency. But we really appreciate you coming along and hearing a bit about this, and if we can help any more, please reach out to the PHN or to me via the PHN, and we'll aim to answer any other questions you might have over time.
Okay, so thank you, Kerry. Thank you, April, for joining us tonight. And thank you for another successful session. Please fill out your evaluation through slido.com, and you just go to live polls and answer the questions. And the information from tonight will be up on People Bank after 24 hours. Thank you.